have now two presentations upcoming. The first will be from Wales. It's Claire E.Hurlin, and she will just provide us with a use case report on Wales. And later on we will listen to Drago Rudel from University of Ljubljana. And so, Claire, it's your floor now.
Thanks very much. As I've been introduced already, my name's Claire E.Hurlin. I'm the Chronic Conditions Lead for a health board in Wales called E.Hurlin University Health Board. Not the easiest of words to pronounce. Okay, just to give you a background to who we are, well, a little bit about us. We are a national health service. The whole population of Wales is just over 3 million. Our health board population is 375,000, but I'll show you a picture of actually the scale that we cover. We must probably have fairly small population to some of you, but the area that people live in is where all our major problems come from because it's such a wide, vast area. We have urban and rural sites. We used to be well known for sheep, coal and steel, but things have changed, and we've got quite a bit of deprivation now because all our mining has gone and our steel has gone from a lot of places, so we've got some real pockets of deprivation, but we've also got some real pockets of affluent areas as well. We very much mirror the picture of Wales itself, so they sometimes call our area Little Mini Wales. So for COPD, we have about a prevalence of 1.87, so in Hywel, that's about 7,000 people. I forgot to put the diabetes up, but I can tell you off the top of my head that we have, with prevalence data, around 22,000 people with diabetes, and growing every day. Our increase is about 5% every year. So this is Wales, and I've tried to circle Hywel Health Board, so you can see that compared to the rest of Wales, we're actually really big. We cover off what we call 3 counties. But they were brought together about 6 years ago as one health board, and that in itself has brought a lot of problems because lots of things were different in each area. And you can see we're very westerly. Our Pembrokeshire site, right at the west, is also known as Mini England, because a lot of people retire and go and live there when they finish working in England. So just to go over what we're doing with diabetes, I've covered off the picture over here because we don't have a call center where everything goes into, everything comes back to the health professionals within the team, whichever team gets the data information, whoever's leading on the patient care with the diabetes. It's mainly in primary care. But the data is never just accessible by one person because you've got to remember that people go on annual leave, people go sick, and you've got to make sure that there's always somebody available to pick up any of our alert messages if there's a problem. So the patient has their device, they do their blood sugars, they choose when they want to do their blood sugars, and then the system we use can just send them a message half an hour before it's due. They all get a self-management plan with a red, amber and green traffic light system, so if their blood sugar is too high, it tells them what to do. If it's too low, it tells them what to do. Our COPD work, which is after discharge, they get a box when they're discharged from hospital. And in it, as you can see, is the tablet. And then their lead nurse in the community also has a tablet. So they Skype with them for up to 2 weeks. Well, they attempt to Skype with them for up to 2 weeks. Then we go down to questions and monitoring for another 12 weeks. And then in Hywel, we will be doing text messaging with them for up to a year. But that isn't... Not everybody's doing that, but we've chosen to add in a text messaging service at the end of it for up to a year. Most of our machines don't have blood pressure monitoring in them. They're just available if the person who's had a COPD exacerbation also has a problem with their blood pressure, but usually it's just pulse oximetry, their temperature, and the questions. We use a system called Florence, and Simple Telehealth, which is owned by NHS Stoke in England. And I just wanted to show you a bit of a back end so you can see what we look at when we go into the web page. Many of us in the UK are old enough to remember Florence from the Magic Roundabout. It was a children's program for many years, but our younger generation coming up don't know anything about it anymore. So that's just showing you what you could see with pulse oximetry. And this just shows you, it records everything that you say to the person on the system you send and everything that they send back in, so that you always know what's happened. You have a record of everything that's happened. Because professionals get a bit twitchy about if there isn't anything written down anywhere to prove what's happened, what's been said. So you can just print all these off and you can put them in the patient's notes. So, challenges and risks with procurement. So in our health board, well, first of all, in Wales, we don't have a technology, telemedicine, telehealth strategy. We are asking for one. We've been asking for one for many years, but we don't have an overarching strategy in Wales, so we feel that that doesn't help us. They have now formed an All Wales group, and the health boards have started to ask for a strategy because it just helps us link systems together, although the Welsh Government is asking us to look at technology. In our All Wales transport plans, there is a section on technology and how we can reduce the need for transport and providing services closer to people's homes. So some of the innovative ways that we've used to get our technology, the health board weren't quite sure if that was the right procedure to take, but when we went to look, was there a process of how to do things? There wasn't a process in the first place. So it's a bit of swings and roundabouts. It's difficult when you're leading the way. We had to do a lot of our own researching for equipment because we found the procurement sessions as part of United for Health came a bit too late for us, and we had to get ours sooner because of getting it into the system, and still we have a lot of delays. One of our big issues is if you're asking primary care services in our area to pick up something new, they like interoperability. They have wonderful systems that record all their patient data, and what they like is for whatever we bring in and offer them, that it talks to it, and it doesn't. So that's one thing that we really need to work on in the future, because we would like a lot of our care just done in primary care and not utilising our secondary care services. Yeah. So, and having the United for Health procurement requirements are too late, and the project could have had, has had a bit of a major impact, I think, on quite a few of us, but that's a lesson learned. We had a change in project management during the procurement phase. I won't look at anyone in particular who deserted the ship, but we felt that just sort of having to get somebody else in, and that just sort of delayed some of our process as well. So it's about having continuity of the same people looking at the system. We also found that when we were looking for the Skyping systems, the tablets and things, that although there were lots of good bits of technology in the UK, it didn't quite match up. And if I can give you an example, is that we decided to go along with Florence and a thing called Wizen technology. But we found out when we put the information on the tablet itself that the first question says, have you had any chest tightness for COPD? Well, lots of the patients don't get chest tightness, so they would say no. But then Florence didn't ask any more questions. So if they had sputum or an increase in cough, there were no more questions to ask. So, and when we asked if we could put that question in, it was going to take too long and delay our procurement and setting up our service again. So we've had to teach all our COPD patients who take on the system that you always say yes to that so that all the other questions come along the way. So what went well? The development of the protocols was great. With Florence, you'd become a community of practice across the UK when you sign up to Florence. And they have like a library where they put a lot of their protocols in. So you can draw off those protocols. You can adapt them for your area, but there's some thinking there already to go on to your decision tree that you put at the back for your patient. The other nice thing is you individualize it, so it's individual to every patient. It's not you, so you can pick and choose the questions you want. We've also managed to put our assessment questionnaire, the EQ5D, onto the Florence system, so we don't have to send out a paper document. They can just answer it through the system they use, either the text messaging, phone, or the COPD with the tablet. The other surprising thing was that we found all our senior and middle management were more accepting of moving on and pulling in technology compared to the people on the ground. So what didn't go so well? As I said, the clinicians accepting work changes. I feel I can say as a nurse, because I'm a nurse by background, that nurses are very protective of their patients, and we really struggle to get them to think differently about what they do for their patients and giving them their independence back. They are too busy trying to tell them what they should do instead of offering them what they should do, and then they pick up that and utilize it, because we don't see them for 99% of their lives. They have to self-manage, and using that technology allows them to self-manage much more appropriately. We have a real issue with clinicians understanding the technology. Because we've had quite a few connection problems, we kept getting messages back from a couple of our nurses that there were technical problems. But they're not technical problems. There's nothing wrong with the equipment. It's just that the connectivity is not there. The connection with the mobile phone system is not there. But they keep on thinking it's a technical issue. But you can fix the technical issue. We can't fix the connectivity. We need the mobile phone services to do that. As I've already talked about the limited timescales we had for changing the technology, we are working to persuade them to change how they do it, but we needed to get going. We also, because with the COPD trial, it's at discharge, we've tried to train up all the ward staff to actually go through the documentation, give them out the information, and then the community nurse picks them up once they've got home. But a lot of them don't want to do it. They say it takes up too much of their time and they're far too busy. And again, we have some staff changes all the time, so you have to keep going back. And unfortunately, the ward sisters don't say, right, we will pick up and run with this, which I think is what you need again. If you don't have your lead person on the ward saying this is what we're going to run with, then the other nurses on the ward feel obliged to say that no or yes, depending on how they feel. So any surprises? The surprises were that the patients or your clients were much more accepting of the new technology than the staff, especially on the diabetes side. We struggled to get sign-up, so we put up posters in pharmacies with our retinopathy screening service. We've been to our local agricultural show and handed out information, and so now the patients can ring in themselves and suggest they want to go on the system, and then we link with their practice, and that way has helped us pick up more people on the diabetes element. The other thing that was quite interesting, which I didn't know, but I'm not technically clever with this sort of thing, but we had the NATO summit recently in Wales, and what happens is when there's a huge mass of use of Wi-Fi or mobile phone in a certain area, the signal reduces, the mast signal. So therefore, one day you might get a big broad area of connectivity and service, but if you have a sudden use of a lot of technology, it brings it down into a much more smaller space area, geographical area. Well, we never knew that, but that was quite interesting because we were wondering why one day you could get connection and then maybe the next week you couldn't, and that most probably is some of the reasons why. Quick few maps just to show you our problems with mobile phone signal. This is how the white spots, no signal at all. We'll just flip through them again. And that's on Vodafone. Again here, the pink, the bright pink is limited. The some indoors and outdoors, some places you only have outdoors. Well, if we're looking after patients who are housebound, outdoor connection is no good whatsoever. We need them to be able to access it inside, and that's Vodafone. 2G coverage only allows text messaging anyway, so you can't use any other system. That's how they are again with the 3G coverage. Again, up in our top area, all that white is no coverage at all. Keep going. White spot there again, same place. And again, this is all I'm rushing through it quickly because I'm behind. White spots again, no coverage at all. So our lessons learned. Utilize your patients or clients early to look at the system and be sure that it suits them. It's more important that it suits them than it suits the health professionals. accept that technology failures are inevitable because we're leading the way. No one else in Wales is using this technology as yet. Be able to adapt the technology and programs and as the lessons are learnt locally, because everyone locally is different and one system doesn't fit all. So you do need to, we found that we will need to have a landline system. We were trying to just go with GPRS and maybe broadband, but we do need a landline acceptance as well. Okay, so we had to give 3 tips. So my first one is training, 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 and more training, because no matter how much you speak to some of the people on the ground, they tell you haven't told them anything. So you have to repeat and repeat and repeat it. Involve the patients, clients, and carers as early as possible, and investigate and understand the logistics of the community, like the signal availability, because we were a bit led into a false sense of security. We thought Welsh Government had told us that there was a really super fast broadband going out, that mobile phone signal was on the increase and it was going to be great for Wales, and then we found out actually it's not. Thank you.
Thank you, Claire. This was quite impressive. One quick question for you. What were the numbers finally you ended up with your rollout? So how many people do you have or patients in COPD, and how many do you have in diabetes right now?
We have about 50 on the diabetes already signed up. We've got about another 50 waiting to just be put on. One of the problems we have is when we do everything by mail, and because we had to go through ethics too, because we were dealing with patients, we have to be sure that they sign all certain places, and sometimes they've been ticking the boxes, so we have to send it back to get them to sign. So we've got another 50. We've sent out over 900 invitations. So we're hoping by the end of most probably October, we'll have at least 100 on the system. COPD has been really difficult. We've had about 50 refuse, and I think that's mainly because when they're having an exacerbation, that they're too ill to be bothered. Because we've had some patients when there's 3 in the room and one says yes and one says no, then you get called back. So if there's a couple of them with an exacerbation in the room, then they all want to sign up. But if there's just one of them, they're not so keen. And we've had ones who've been into hospital, gone home and come back, and then they've signed up again. And we've had about 50 refusals, and we've got about 37 on. But our real problem is the connectivity. Because as soon as it doesn't start to work, then they get irritated and they want to come off it.
Okay. Thank you. We will